So this morning, and we're going to talk about a topic that's really important to all of us, and that is changing the face of how we are doing medicine. It's one of the sort of hip topics, if you will, in medicine right now that's important for all of us to be aware of. And the great news is that we have, one of the thought leaders on this topic in our department. So big data is around. It's coming. There's a lot of new activity that's being born out of the work around big data. So with that, I'm going to turn it over to Soman to explain to us what this is all about.
Thank you very much. First, I want to disclose that I have nothing to disclose except that all these opinions from this talk are mine. And this is a brief overview. This topic is very complex. There's so many different avenues to explore, from ethics to are we really even finding the truth through big data. I made the URL for the references public on my NCBI, and if anybody wants a copy of that URL, I can email it to you. So just shoot me an email and I'll send you the URL. We're going to look at big data from a couple different standpoints. About maybe 15 years ago, we were pretty much all analog, so how did we get to digital? We're going to look at meaningful use and how screwed up it is. We're going to examine the benefits and pitfalls of using big data for research and quality and improving patient care. And then we're going to, hopefully, if I have enough time, explore or look at our surgery meta-registry that we recently created that none of you have access to, but hopefully we'll be able to get you access. And you guys can use that as part of our big data initiative. So what is big data? There's a lot of definitions of it. It's literally everything that you can collect under the sun. For healthcare, it's not just stuff that we put into electronic medical records, but it's data searches that people do on social media, on Google, on the internet. It's also what you buy in healthcare in terms of going to doctors and procedures. It's buying cough syrup at Target. They're looking at all sorts of stuff. And it's continuously stored. So it's a continuous database. It's organic. It can comprise lots of different things, from food buying habits to refilling your medications. So if you think that something is related to your health, then it's probably being recorded whenever you do something. How big is big? Well, there's a lot of estimates out there. It's hard to say. 2011 estimate is that worldwide there's 1.8 zettabytes of big data in healthcare, about 150 exabytes in the US healthcare system as of 2011. You might ask yourself what a zettabyte is. Zettabyte's about 1,000 exabytes, and on and on and on, all the way down to gigabytes. So that was kind of hard for me to get a good handle on. And since everybody I know has an iPhone, I broke it down to 64 gigabyte iPhone. So if you used a 64 gigabyte iPhone, how many iPhones would that be? So in 2011, that would be about 28 billion iPhones, or about 4 iPhones for every person alive in the world. In the United States, in 2011, that would have been about 2.3 billion iPhones, or about 7 iPhones per person. But that was 2011. Turns out that most experts in this field agree that healthcare data is doubling every year, so we've gone up a lot since 2011. And at the current rate, we're going to reach yottabyte level in 2020, which is 1,000 zettabytes. So I don't think we can make enough iPhones for that. As a reference, Kaiser Permanente has 9 million patients. They're keeping in their database, and they're big players in the big data market, between 26 and 44 petabytes of information. As a reference for what we do, In the University of California system, we estimate that we have 12 million patients in our network, and we do store a lot of data. So we're probably a little ahead of Kaiser, but Kaiser is way ahead of us in terms of using this data. So, and we'll talk about more of that in just a second. So how did we start? Well, this story is going to be mostly about the United States, and it's a story of the carrot and stick, and it started with carrot, but like all stories with the government, it ends with a big stick. So healthcare accounts for a big part of the gross domestic product of the United States, about 18% of it. As a reference, the US defense budget is only about $600 billion. So we spend a lot more on healthcare. And because of that, there's been a nationwide movement for the last part of the last decade or so to really cut back on healthcare costs and to improve efficiencies. And one of those ways that the government felt we could improve efficiencies, and a lot of healthcare experts did, was through transformation of the US healthcare system from analog to digital. So in 2004, President Bush announced that he would like us to change everything in healthcare to an electronic medical record for every person alive, so that their medical record would travel with them anywhere they go and you could access it. I think most of us would agree we're not there yet, 12 years later. He created the Office of the National Coordinator for Health Information Technology, and he gave them a whopping $42 million. Now, if you compare that to the total amount of money spent in healthcare, it was only 1.4%. And they were supposed to incentivize hospitals and physicians and healthcare providers to change what they were doing and adopt electronic health records. Well, that didn't work too well, and by 2007, only 10% of all hospitals and physicians had converted over. So what was needed was a giant event, something that was going to transform the world in order for us to adopt electronic healthcare records. And that event was the 2008 financial crisis. It actually started in 2007, and we're well aware of what happened, even though it sometimes seems a little murky, but basically Wall Street screwed us. Because of that, the economy lost a tremendous amount of money. Gross domestic product went down, and a total of $12.8 trillion was lost. So Congress and the president at the time decided we needed to stimulate the economy, so they created the American Recovery and Reinvestment Act, and that was passed in 2009. In that act, they funded what they called shovel-ready projects. Shovel-ready meaning that these projects were ready to hit the ground and make a difference, hire people, stimulate the economy. Among those shovel-ready projects they thought were ready to go was the ONC's vision of changing electronic health records across the United States. So they allocated $36 billion to this project from that act. They also passed the High-Tech Act. The High-Tech Act allowed the UNC or the ONC to mandate that all healthcare transform over to electronic healthcare from digital healthcare. They started with the carrot of giving out incentives, and those incentives were much higher if you did it right away and much lower if you waited, and then there was going to turn into a stick if you waited too long. And that started the meaningful use. So meaningful use is basically trying to transform, or at least transforming, healthcare into electronic medical records that would provide meaningful use for patient care and patient care and healthcare quality. And it was implemented in 3 stages. So stage 1 finished a couple years ago. Stage 2 just finished, and we're supposed to be in stage 3, but I'll tell you if we really are or not. It was a pretty big carrot. We went from 42 million to 36 billion. By the way, all that money's gone, so it's been all paid out. And by 2014, 70% of all healthcare providers have been transformed to electronic medical records. Stage 2 concluded at the end of 2013, And in stage 2, they really upped the requirements that you needed to have for electronic health record reporting. They upped all the benchmarks, and they started to say or threaten that if you didn't achieve your benchmarks, you were going to get your Medicare reimbursements cut. In total, 32 metrics were changed for stage 2, and then the stick came out. So after 2014, there were no more incentives. Now there were penalties. Penalties were in cuts to Medicare reimbursement, and in 2015, that cost the healthcare system $600 billion. But it turns out that a lot of healthcare systems and doctors were okay with that, because it costs a lot more to tool up to what stage 2 meaningful use was going to need relative to the payment cuts they were going to get. So although that stick was pretty big, it didn't really do very much. And this breaks down where the reductions have happened. So by 2017, if you're not compliant with stage 2 and stage 3, you were going to get a 3% reduction in your Medicare reimbursements. A lot of complaints, if you can imagine. And January of this year, the CMS administrator said that meaningful use was pretty much on its way out. In addition to that, Congress passed exemptions for hardship for healthcare providers and doctors who couldn't meet meaningful use, essentially eliminating any real payment reductions and penalties that were going to occur in 2016 and 17. But actually, meaningful use is in hospice. It's been renamed and repassed as the Medicare Access and Children's Health Insurance Program Reauthorization Act of 2015, MACRA. So what MACRA says is that all the physicians in the United States and all the healthcare still needs to adopt our EHR standards. The difference being that we're going to allow you some flexibility to make it the way you kind of want to make it rather than the way we want you to make it, but not so much because we're still going to implement stage 3 meaningful use. So it's really confusing. When you read this topic, you know, in the literature online, it's really hard to say what exactly they want us to do. Do they want us to be flexible and be able to communicate our data, or they want us to fill in the boxes that they have set? And I think they want both. So for stage 3, these are the things they want us to have. And I think what's really challenging is the health information exchange, because what that's saying is that they want us to be able to exchange data across different platforms, across different types of EHR vendors and software, and have this be totally streamless and or totally seamless. And I think that's a big problem right now. So where are we now? Well, it's a mess. In January this year also, 31 healthcare systems across the United States petitioned the Health and Human Services to stop meaningful use. They said that it would limit innovation, and they said that their physicians and healthcare providers are spending more time on the computer and less time dealing with patients. I think that's something all of us would probably agree with. And there's less of an emphasis on outcomes with the way meaningful use is kind of set up. Are we really improving care through adopting this EHR system? Right now, it looks like across the country, we're kind of 50-50. Most places are a little over 50%. I don't know why Minnesota's at 90%. There's something weird going on there. But otherwise, we're not really adopting it in a high rate, and not in the way that the government and President Bush had envisioned in 2004. What are some downsides to it? Well, the problem is that we rush to convert to use it. So there are 392 EHR vendors. They all make different software. Some of them are very big, like Epic, and have a lot of the market. Some of them are very small. There's doctors' offices using different EHR software than the hospitals use. And because of that, there haven't been any real standards established. There haven't been really any data communications established. And so how do you communicate data from one enclave to another is still a big problem. We also, in the middle of all of this, changed ICD-10. So it's really gummed things up. I'm going to contrast that briefly by talking about the history of the Patient Archiving and Communication System, otherwise known as PACS. So the PACS system is also a high data delivery system, and it was first introduced in 1979, and it was introduced at a conference about how you can set up a system to share high quality digital images such as radiologic images within a hospital. Throughout the 80s and 90s, a lot of interest was generated in PACS systems. A lot of presentations were made at various conferences. The US government got involved. The DoD and the VA were one of the first adopters of PACS and stimulated a lot of research. And it mostly stayed academic within the research realm. And because of that, they were able to develop new technologies and new software that all talk to each other. They also were able to develop standards for sharing of data and the quality of data that was going to be shared. By the 1990s, most academic institutions adopted the PACS system, and it spread throughout from there. If we compare that to the way we did EMR, it took us about 25 years or so to get PACS up and running, and we tried to ramrod EMR in about 6 years. So if we look at the difference in just the total amount of time, we didn't spend the time with EMR that we should have spent developing it. But we're here now. We have it. We're using it to some capacity. We're not really achieving the meaningful use that the government wants us to, but 70% or 80% of hospital systems are now using some form of EHR. The sharing and easy portability of data doesn't exist, but EMR is just one part of the data universe. The other parts of the data universe are research studies and research databases that have been created. Financial databases and what is purchased in the healthcare system, also what's billed for in the healthcare system. The internet, and everything you guys enter into the internet, whatever it might be that's related to health, is all being sucked into some database somewhere. And then the new avenue of wearable and shareable technology, all of us, those of us with iPhones, I bet you Apple's just taking that data about how much we walk and how far we walk every single moment that it can, without really maybe us knowing. It's hard to say. But your Fitbits and your remote whatever that's checking your health and activity, that's all being collected. So this is a giant universe of technology and databases that are sometimes sharing information and sometimes not. A lot of information is being collected without anybody knowing about it, and there's some ethical issues about that. And it's also a big business because storing this data is huge. Amazon Wireless Service is a division of Amazon, and it makes more money than their retail service does currently. So Amazon, and I think UC Davis is in some negotiation with Amazon Wireless Service about using their cloud service to host some of our data. So we're in the big data universe, and there's a lot of money being made by a lot of people, and that money can manipulate the system. So what are some pitfalls of big data research? Well, one of the good things about big data is that it's everywhere, and you could probably access it fairly easily. You don't need to put patients in harm, at least physically. You do put their privacy at harm, but physically you don't have to put them at harm. You can quickly put together a research study, but you have to be careful because the data is not collected for research purposes, and because it's not collected for research purposes, your research question may not be answered by the data that you have, even though you might think it is. A good example of that is financial data, where if you look at billing codes for hospitals, well, those billing codes are coded not by physicians usually, but by billing coders who sometimes are incentivized to upcode based on certain things that are in there and may not be so accurate. So you kind of have to be concerned about that. There's also lots of areas of missing data and variable data fields, and you might define a particular field in one way, but the person or the entity that's collecting that data might define it completely differently. So you have to know your data. You have to investigate what those fields are and understand what was collected and how it was collected. And the missing data can create bias. It can create bias in terms of who you're looking at and what you're looking at. One example of that bias is a study in 2010 done by the Anesthesia Quality Institute, and they were looking at the incidence of a rare event, which was malignant hyperthermia. And they looked into their database of 27 million anesthetics that were given during surgery, and they found that the details were sparse in that database. It only kind of told you what drug was given, so they decided, well, we'll look for dantrolene, because anybody who got dantrolene probably had malignant hyperthermia. They found this outlier hospital that had a huge, huge incidence of dantrolene administration. And what it turned out to be was that it wasn't dantrolene that was being administered, it was dexamethasone, which was the drug in the registry listed right below, and people were clicking the wrong thing. So they were clicking dantrolene instead of dexamethasone. Another way that data can be biased is kind of who are you sampling? So have any of you heard of Google Flu Trends? So Google Flu Trends is this project from Google from 2008, and they have been collecting data on searches for flu symptoms. So anytime anybody searches for a flu symptom, Google tags that. And they use that plus some CDC data to quickly identify epidemic or outbreaks in flu. So Nature published this in 2008 and thought this was revolutionary and great. Only one real big problem, and that was it was wrong. The reason why it was wrong in 2008 was that was when we had an H1N1 outbreak, and the media covered that when it was all over the place. And because it was all over the place, people started searching, well, I got a little cough, maybe I have H1N1. And it turns out that not as many people actually had the flu than were searching, and they overreacted to the flu, or overreacted to the H1N1 epidemic, and Google said that the flu was twice as prevalent than it actually turned out to be. So Nature wrote an article saying that, well, we were wrong and Google was wrong at that time. Well, Google's still collecting it, and in 2013 they were wrong again. But the interesting thing this time is Google hasn't told us why they were wrong this time. They sort of just kept that data quiet. So what happened here? Well, this is an example of exhaust data. Exhaust data is basically the data that's collected after you've searched for something. So if you're buying a pair of shoes and you go on some search engine to look for those shoes, most of you probably noticed that when you go to a website, let's say you go to like the NewYorkTimes.com afterwards, that an advertisement for similar sort of shoes sort of pops up. Well, that's an example of exhaust data. That's the search engine grabbing that information about you and then regurgitating it as an advertisement to you. So in this case, this exhaust data was about flu symptom searches. So you think, well, that's a large population of people, and so it should be relatively okay. The problem is that exhaust data this time was biased or influenced by the media hype of H1N1. And because of that, the searches were abnormally large, but Google couldn't account for that at the time because they were turning over this data on a one-day basis. So in one day, they already had pronounced that there was an epidemic without actually filtering through and drilling down as to why the searches were so high. So in terms of this big data, you might say, well, it's a huge sample size, so we shouldn't have sampling bias because N should equal all, but it doesn't actually equal all in big data. The 1936 presidential election is a great example of that. So that was Landon versus Roosevelt. And in that election, the Literary Digest did a survey of 2.4 million people. So they sent out 10 million surveys, and they sent them out based on automotive registration and telephone directories. And they got 2.4 million of it, and they said that Landon would win in a landslide. George Gallup, who performed a similar survey, surveyed only 3,000 people. The difference being that he interviewed all the people that he surveyed so that he would get sort of a mix of people that would vote for the presidential election. And it turns out that Gallup was right with his 3,000 sample survey. Roosevelt won in a landslide. So the reason why Literary Digest was wrong is because they sampled more affluent voters. They sampled voters with money because at that time, only people with money actually owned cars. And so this is an example of creating a bias or creating a disparity in who you're sampling. So so within the Google flu trend, they sampled everybody who uses the internet and then searched for a flu symptom. Well, it turns out that not everybody uses the internet, or internet access in itself is actually very limited. It's something called a digital divide. In 2012, the Pew Report reported that 62% of households earning less than $30,000 per year use the internet. Compare that to over 90% of the households who earn over $50,000 a year using the internet. So there in itself, if we just used internet data to perform a healthcare research, we're already creating a disparity, an economic disparity. There's also an ethnic disparity in that only 49% of all African Americans have high-speed internet at home, and only 51% of Hispanic Americans have high-speed internet at home. This followed up to see, well, is there any changes over time now that we have more mobile internet access through our phones and things like that? Turns out still that economic disparity exists. And that disparity is a big problem because what you're saying is if you have this huge sample size, but you've excluded a bunch of people that may not benefit from the research that you're doing or may change that outcome of the research that you're doing. And so you have to be very careful about that. That disparity is even larger globally, where a lot of healthcare data is being collected. We talked about the 1.8 zettabytes, but if you look at it, a lot of that healthcare is being collected from countries that actually have a little bit more money. The poorer countries across the earth aren't sending in that data. So what is it that we're actually collecting, and who is it that we're collecting on are very important questions whenever you're exploring using big data for your research or healthcare quality initiatives. But big data is the present and the future. Big data is being used for public surveillance, for disease reporting, for quality initiatives, for research. But the real big key to all of this, with all these disparate and variable databases, is communication. We need to be able to develop communication and develop systems that accomplish harnessing big data, because there's a lot of volume of data. There's a lot of variety of it. It's coming from everywhere. It's coming at us very fast, being collected continuously. And we have to be able to develop processes to analyze the truthfulness of that data, because the veracity of that data is extremely important. You could have data that you think is telling you what you want, but it really isn't. In the healthcare system, this is kind of an example of the types of healthcare data that we can collect. And you can see that it's collected in variable amounts. There's things called structured and unstructured data. And we'll go through that in a little bit more detail. But structured data is basically data that's entered into a database without interpretation. A good example of that is blood pressure. If I want to know you would enter in the systolic blood pressure of a patient. Unstructured data are things like clinical notes. So things that we write that need some interpretation. And unstructured data is very complex. There are people working on this that are very smart to try and glean data from unstructured data. And unstructured data is probably the gold mine, because that gives us a more detailed and granular assessment of a particular patient themselves. But structured data is probably more reliable overall. So then, again, know your data is a big theme of this talk. We have to be able to communicate and form collaborations with lots of different stakeholders in the data world. Because if we're the data researcher, or if we're the data quality initiative person, if we're the healthcare system, and we want to integrate all of this, we have to create partnerships with different groups who are all hold this data, and they all hold it very, very tightly. And we have to incentivize them to allow everybody to research, or allow everybody to share that data. One such collaboration exists through the NIH. It's the Healthcare Systems Research Collaboratory. And its goal is to rapidly produce clinical trials from existing databases. So to take databases that people are already collecting, merge them together, assess the veracity of these databases, and then produce results that would have some type of real-world applications. It's occurring across the United States. There are healthcare research collaboratories all over the place. There's a bunch here in California. And there's numerous studies that are undergoing right now to answer some very complex questions very rapidly. One of the things is you need smart people and people with some health information experience and analytic ability to be able to process this data quite rapidly, but also integrate the data so that you are mixing together two disparate data forms into something that's very usable. Another example of this is the Mini Sentinel program through the Food and Drug Administration. It's a collaborative of 21 hospital systems, and this is a rapid response system to look at drug interactions and drug safety. These 21 hospitals share all their data together within the Mini Sentinel program, and you can query this database to look at outcomes from different types of medications. You can look at the efficacy of these medications and the safety profile. It provides a laboratory so that you can quickly look through this database to find out information and come up with results very rapidly. The way it works is that data is shared and filed into a core system. That system, because of the agreements and collaboration of how we're going to collect this data, it can be shared pretty easily, and then you can go to the query system and query and send in a query. Now, we can get access to this actually, but you have to request access from minisentinel.org. And then you can send in your idea of what you want to do and query and then work with their system. It looked like, at least from what I could see, not too hard a database to query. It might take a little bit of time to get facile with it, but a number of studies have been produced from this database, and very interesting studies looking at different drug-drug interactions and different populations. All the patients in there have ICD-9 codes of diagnoses, so you can look to see what are the outcomes of patients with atrial fibrillation who have had below-knee amputations, and kind of look at some drug-drug interactions with two different types of drugs. One thing that we're interested in on the burn world is we use a lot of atypical antipsychotics, but we're not sure what the drug interactions are with these atypicals with all the other stuff that we're doing. This would be a quick way to actually do a large population study. Big data is used in surgical quality, and we're all familiar with NISQIP. One interesting thing though, and this goes back to our issue with structured and unstructured data, is how useful currently is subjective data versus objective data, meaning data that requires interpretation versus data that doesn't. If you notice, the lead author on this paper is our own Jamie Anderson. And this is a very interesting paper that they wrote. They compared comparing 66 subjective variables to 25 objective variables to see what was the performance if we took out all the subjective variables and just looked at objective measurements. Their concern was that the subjective variables, because they are interpreted, could be embellished or diminished based on who was interpreting them. Because you might think, well, they're just putting in, a term that could be objectively pulled out, but the reality is that somebody entered that. They could say that this is complex cholecystitis instead of just simple acute cholecystitis and things like that. So this really is the difference between machine versus man, and it turns out that the objective data performed as well without the subjective data, and so it's possible that just using structured data or objective data is better right now until we get a better feel for how to use the better use the subjective data. Another way big data can be used is in teaching and in teaching the residents. And this was an article that I really liked because it brought out the possibility of changing morbidity and mortality conferences. Right now, we basically say, okay, if there was a complication, then we need to present it. But this article asks the question, what if we were to break down our complications into expected and unexpected results, both for things that happen bad and things that happen good? Because there's things to learn from not just our failures, but sometimes our unexpected successes are just as important because there's information in there. It also allows for us to better interpret what happened, to say that, okay, this was an expected outcome from this patient, but this patient, that was not an expected outcome based on their profile. And I think it would be a better way to advance education and learn some insights from our experiences with patient care. So ultimately what we need to develop is analytics for big data. And analytics for other kinds of big data out there, financial, even in the sports world, are so much more advanced than we are right now. And the reason for that is a lot to do with healthcare data is very complex. And we're not communicating very effectively within our hospital systems. We have a lot of databases that we can't share or don't want to share. And there's a lot of variables, because as a person looking at the EMR myself, I can't really analyze all the variables. This study looked at how many variables a person can process at a single time. And they used 30 volunteers, and they gave them questions that assessed how many variables they could process. So in this case, they had to process 3 different variables about the different types of cake, plus the different types of cake themselves. So that's a 4-variable question. And what they found was that up to 4 variables were okay. So 1 to 3 variables were about 100% success. When we get to 4 variables, we got 23 out of 30 correct. But after 4 variables, when we get to 5 variables, we're no better than chance at figuring out. On top of that, trying to figure out 5 variables or more took us a lot longer. So our average capacity, some of us are better than others, but our average capacity to assess a situation accurately is probably with about 4 variables. So if we talk about the thousands and millions of variables that are collected all the time, we need some sort of computer analytic to do it because of the large nature of databases. And what we really want to do is we want to integrate big data ultimately into our surgical practice. We want to be able to take all these data elements, have them analyzed, and have them then be combined with research databases for outcomes and say, this is the right thing that we should do for this patient at this point in time. Or we want to take large clinical databases and put our patient profile in and then be able to give them an accurate assessment of what's going to happen to them. Are they going, what is their risk profile for complications or death, or whether or not we should even operate on them. But we're not really there yet. We have some calculators that do help us, but they don't take into account the large number of data variables that are out there. But we're getting closer. So this study was out of MIT. And these very smart people asked the question, can we predict post-op surgical mortality from structured data immediately after surgery? And they assessed the situation similarly to most people who are working in this area. There's a problem with time because we're continuously assessing variables. There's a problem with patients because each patient is different. And then there's a problem with variables in that they're not all collected, even though we might want them all to be collected. So they created this system in which they would take this data, they would organize the data based on different elements, laboratory, demographic, vital sign. They then normalized the data points that needed to be normalized, transformed the data, and filled in the missing elements based on some logistic regression, and then made a prediction out of that. What they found was what we would expect. If you took all these variables and they looked at 44 different variables, they're all measured at different frequencies and different amounts, and sometimes they were missing and sometimes they weren't. They used some computational analytics to develop their algorithm, and then they tested it. And they did their test with just patient data itself. So this is an in silico model. And what they found was that their model worked out pretty well, that their analytic model had a pretty good predictive probability and a pretty good accuracy. And then they compared it to using other outcome measures like SOFA score and things like that, and they found that their proposed method worked better than most of the other methods. So this is kind of an early foray into using analytics. Now, MIT can do this, but most other hospital systems will require some buy-in or some collaboration with industry. In this example, Dell Computer collaborated with University of Iowa to look at post-operative or surgical site infections, and they created an analytics which I tried to find how they did it, but it was very, very hard. And all I could tell you is that they report a 58% reduction in surgical site infections. Now, I'm sure that it's hard to find because Dell wants to sell this to somebody else. So that's one part. And a lot of these big data initiatives are using structured data. But unstructured data is really, really where the gold mine is. And I think that's where our future is going in terms of big data. Everybody's heard of IBM Watson, and they partnered with Seton Healthcare in Texas. And they were able to do a study with Seton Healthcare to look at predictors of readmission rate. And so they use natural language processing and looked at clinical notes in addition to objective measures, and they were able to find 18 unique clinical parameters that they found from their unstructured data that predicted congestive heart failure readmission rates. So another study looked at the prevalence of heart failure signs in a primary care setting. This is again with IBM Watson, and this was Geisinger Healthcare System in Pennsylvania. And they looked at 51,000 patients and 3.3 million notes. And they mined this system using, again, natural language processing software to look at our notes. And then they were able to find unique identifiers for outcomes from congestive heart failure. And they found something very interesting, that the notes themselves actually predicted patients who were eventually going to get a diagnosis of congestive heart failure about 6 months and even sometimes 1 to 2 years before that diagnosis was actually made. And in fact, they concluded that if we were to be able to develop a system that could do this in real time, it would pick up a lot more patients who had congestive heart failure that we ourselves as physicians miss. Now you might think, well, could it be that much better than us, this natural language processing and IBM Watson? Well, consider this, that there are reports out there that our diagnostic error rate ourselves could be up to 33%. So we're missing diagnoses, and having an analytic software tool that will give you an alert based on the clinical notes and other signs that are in the EMR would be extremely helpful to reduce that rate. So what are we doing here? Well, we have UC Braid here, which is a collaboration of 5 UC hospitals, and they link 14 million patients through UC Rex, which is the UC Research Exchange. UC Rex is this large database of clinical data, and you can query UC Rex right now online to get an idea of the cohorts that are of a particular issue. Like I can query, adult burn patients who have a psychiatric illness and figure out how many patients are in the system and broken down by hospitals. But beyond the cohort information, I can't get anything else. Locally, we have something called Cohort Discovery, which is, again, a large database of patients that feeds into UC Rex. You can also query this database. The difference is here, with an IRB-approved protocol, you can actually get the data from that. Now, you can query it based on ICD-9 codes, laboratory values, vital signs, and medication. One thing to note is, if you're not real specific, they're going to give you a lot of data, and it's sometimes a little unwieldy to work with. But I've done a number of things with Cohort Discovery, and it's a fantastic database. But you have to be careful, because sometimes patients are assigned a diagnosis that you don't think they really have. So we've had patients that have been assigned burn diagnoses that when we look back through and compared our registry to the cohort discovery, find that those patients don't exist. So it does take some editing. The problem is that we're not really there yet with collaboration, because although we can do some collaborative, we can look at cohorts and things like that, we can't really share our data across a portal, or an easily accessible portal, with other UC hospitals. There's nothing like Mini Sentinel out there where everybody feeds into this database, and then I can query the database and get all this data and do a really quick, multi-center research study on a particular topic. That doesn't exist at all at UC Davis. There are efforts to increase that collaboration, and also efforts to link research databases with this clinical database, but still, as of yet, those don't exist. It's also the issue of ethical dilemmas, because that's really the fly in the ointment for big data, is that we're able to gather all this data, but we're not really informing the public about what we're doing. This data is just there. We're currently, with retrospective studies, don't inform the public, but people have questioned whether or not you can use their personal data to do research, and whether or not that's something that the public should know about on some level. And then there's a blurred line right now between quality improvement and research. And we kind of skirt that line. We kind of say, okay, well, this is a quality improvement project. We don't need to we don't need to get any regulatory approval for that. And then all of a sudden we turn it into a research proposal and get a quick approval for it. The rest of the big data universe, industry, politics, government, they're able to target people without their permission, right? They take your data, and next thing you know, you get a flyer to vote for Bernie Sanders in your email, right? They can target you without you knowing about it, and they can target you without any permission from you whatsoever. But in the healthcare world, we can't really do that necessarily. There's HIPAA laws that are murky. There are research regulatory issues with what constitutes human subjects research versus what doesn't. And we have not really entered into a public discourse with the general population about the fact that we want to use this data to improve healthcare, because really it's kind of just fallen in our world, really. An interesting study, one that I thought was interesting to do, was this personal genome project actually interviewed people who were in the study and asked them how they felt about their data being used currently and in the future. Like, here we have all of your genes and your whole DNA, and we're just going to keep it and keep studying it, and maybe we'll find something later on down the line, and how they felt about that. And they had different responses to it. Some of them felt good about being able to be part of the process of helping people and being a part of research. Other people were worried about, well, what if you find something and you make $1 billion off of it? Don't I get a little bit of it? Right? And those are questions that are continuously being asked. And then there's the issue of privacy and security. All of our data now, everything about us is on some cloud database that can be hacked. If you don't think it can be hacked, just wait, because it will be. And we're just a fraction of a step ahead of the hackers who are getting into databases all the time. And so we have to be wary about where we keep our data. We're going to keep them on our laptops and thumb drives, and we can download a whole spreadsheet, and then it'll be on our laptop, and our laptop's not password secured, and then somebody has access to it. I mean, there's all sorts of simple ways that privacy can be broken. So before we go into tethered meta registry, I just wanted to go through the guideline overview. So my big theme is know your data. Know where it comes from, know what it is, know who's collecting it, how it's being collected, why it's being collected, what the data variables actually mean, and does that line up with the questions that you're trying to ask. Understand the limitations of your data. Like, how much information am I gathering from this? Google FluTrans is a great example of that. It looked like that data didn't have any limitations, except it kind of did, because it was not only influenced by the media, but it was also limited to those people who actually cared enough to put in flu-like symptoms into the Google search engine. Be wary of regulatory issues, right? You may think, well, you know what, this is collected data and I don't need to worry about telling the IRB about it. And be wary of that because these regulatory issues are becoming a bigger deal, and ignorance is no longer going to be tolerated. So you can't be ignorant of the rules when you're doing research. And then we should all have a discussion on some level about the ethical issues of using all of this data, because eventually we're going to be able to drill this data down to identify the person from whom this data comes from. And what does that actually mean in the long run? Okay, so I briefly wanted to go over this surgery tethered meta registry. This was an initiative that we started last year. And it's basically structured data from the EMR that we pulled out and we put into a database. This was in collaboration with the Meta Registry group over in the cannery with Sharon Myers, and then my team here, Katrina and Mary Beth, helped out a lot in facilitating developing this. It's algorithm driven, so it's an automatic tethered database. We pulled the data pulled out straight into the database. No one enters in any data except for the data entry on the front end through EMR, the laboratory information system. We didn't do any unstructured data, so we didn't do clinical notes, we didn't do radiology interpretations, we didn't do OR notes because we don't have the capacity to do that currently. Right now you need to request access for it. But those of you who are interested in being a part of this project, just email me and we'll set up some time to get together and kind of get more involved in it. And I wanted to tell you that it's pretty raw. We took data from OpTime and laboratory information, and this is the URL. But I can email this to you, if you guys are interested. And let me log into I'll just give you a quick example of it because I know we're running out of time. Not that. All right, so this is the entry portal. Nope. So you just log in, and so the login will be your Citrix password. Okay, so you go over to the clinical registry side, and then there are two types of surgical registries. The first type is the dashboard, which is just surgery, and then the other one is the surgical data set. We'll open up the data set one first. And so this registry is refreshed continuously. It's been collected from March of 2015. It has about a 3-month lag, so although it'll say February 2015, it actually has collected up to November. And then once that 3-month period is gone, it'll collect again. All right, so this is the data that we're collecting. I'll put this at... So we're currently collecting data for all the surgical services within the Department of Surgery, an age range from 0 to whatever, and then all of the procedures that are listed in OpTime. So one of the reasons why we chose OpTime was that it was a discretely structured field. OpTime doesn't necessarily capture what you actually did, so that's one of the downsides to this database, but it will give you kind of an idea. So we have the procedure, who did the procedure, what type of surgery was it? Was it an emergent surgery, an urgent surgery, an elective surgery? We have length of stay. We have the ASA scores. We have the time from admit to operation. We have the total time of the operation, which we called OR in and OR out. That was actually pretty complex to try to figure out because we had to figure out, because those times are all entered in a little differently in the system, so we had to create a composite of that. We did total ICU hours if the patients were in the ICU. We also did vital signs, so we looked at admit vital signs. And so you can see here we looked at the admission temperatures and then also the post-surgical temperatures. And so all of our data points are either admission or post-surgical. We would like to collect everything, but they don't have the capacity in the registry system to collect everything, so we're not quite there yet. You can filter this by the type of operation. So let's say we wanted to look at amputations of the foot. You can see we did 3 procedures that had amputations of the foot, and you can see their outcomes from here. The next type of registries that we have is our dashboard. So now that first type that I showed you, that's all the data that underlies this dashboard. That data is not going to be accessible to everyone. That's going to have to be on a by request basis because that's identified data currently. But you can make a request, either have an IRB approved protocol or make a request for a quality improvement project and then be able to get that access to that data. This data is the dashboard that pretty much anybody probably will be able to use. And the dashboard here just aggregates the data into graphical form. So here you can see that we looked at the average length of stay across all the services and based on encounters, and you can see we're the outlier burn. We have a huge length of stay. And then you can see this is, on this side, this is the average length of stay for everybody who got a surgery or who didn't get a surgery, who were admitted to the surgical service, and this is for everybody who actually got surgery. We can filter this down in this form. Now, this dashboard is a little raw. It's not the best in the world, but you can filter on this side by service, by age group, by admission type, by procedure, and then you can look at the total surgical encounters. We can break it down into the most common procedures that were performed. We can also look at, let's see, vital signs, laboratory values. Sorry, I'm running out of time, so I just wanted to whip through that. And there's a lot of things you can play with, manipulate the graphs, look at different things that you want to look at. We're open to ideas. We started this as a pilot project to try and see what we could get, and working with the registries and trying to figure out the data points. But if there's other things that people think would be of value, we'd be happy to add that to version 2. Version 1 is very raw, but we are happy to update that. I'm sorry for going over. I'm happy to answer any questions anybody has. And if you have any questions that you want to just email me about, just go ahead and email me. Thank you.